Neurology quiz number 118. Describe the pathogenesis, clinical features, and treatment of carbon monoxide poisoning. Carbon monoxide is a colorless, odorless, tasteless, and non-irritating gas produced by the incomplete combustion of hydrocarbons. Ambient concentrations are typically below 0.001%, but levels can be higher in urban settings or in poorly ventilated spaces. Causes of carbon monoxide poisoning include smoke inhalation from structural fires, such as a house fire, malfunctioning or poorly vented heating systems, gas-powered devices used indoors, such as charcoal grills, camp stoves, generators, and kerosene heaters, and vehicle exhaust in confined spaces, such as in a garage, ice rink, or parking structure. Because of its physical properties enumerated earlier, carbon monoxide is also known as the silent killer. Non-fire-related carbon monoxide poisoning accounts for an estimated 50,000 emergency department visits and 1,000 to 1,300 deaths annually in the United States. Unintentional carbon monoxide poisoning occurs more frequently in colder climates during winter months. Accidental non-fire-related exposure causes an estimated 400 deaths each year. Fatalities from intentional or suicidal exposure are twice as high. This graphic shows some of the leading causes of carbon monoxide poisoning, including furnaces, stoves, fireplaces, water heaters, and running engines. Pathophysiology. Carbon monoxide rapidly diffuses across the alveolar capillary membrane and binds to the iron moiety of heme with a much greater affinity than oxygen. Baseline carboxyhemoglobin levels are less than 3% in non-smokers and less than 10 to 15% in smokers. Carbon monoxide binding to hemoglobin reduces the oxygen carrying capacity of hemoglobin, impairing tissue oxygenation. Carbon monoxide inhibits cellular respiration by binding to mitochondrial cytochrome oxidase, especially affecting organs with high metabolic demand, such as the heart. The delayed neurologic sequelae associated with carbon monoxide poisoning are not fully explained by hypoxia alone and likely involve lipid peroxidation from toxic reactive oxygen species. Carbon monoxide elimination. Carbon monoxide is rapidly absorbed through the pulmonary vasculature. Its elimination depends on oxygenation status and to a lesser degree on minute ventilation. The half-life of carboxyhemoglobin is 250 to 320 minutes on room air, 90 minutes with 100% oxygen via a non-rebreather mask, and 30 minutes with hyperbaric oxygen. Clinical features. Number 1, encephalopathy. Symptoms are non-specific and most common presenting symptoms include headache, dizziness, drowsiness, fatigue, nausea, and vomiting. Severe toxicity can present with seizures and coma. A characteristic cherry red appearance of the lips and skin has been described in the literature but is uncommon. Number 2, myocardial injury. Acute myocardial injury can occur and presents with myocardial infarction, arrhythmias, and shortness of breath. Myocardial injury is associated with increased long-term mortality and is reported to be twice that of patients without cardiac involvement. Delayed neurological sequelae. Number 3. Up to 40% of significantly poisoned patients develop neurological side effects several weeks to months post-exposure. Most cases occur within the first month after exposure. Features include cognitive dysfunction, personality changes, movement disorders, and focal deficits. They are more frequent in cases involving initial loss of consciousness. The basal ganglia, especially the globus pallidus, are reported to be particularly susceptible to the effects of carbon monoxide. This chart shows the clinical effects of carbon monoxide poisoning with mild, medium, and severe exposure. Diagnosis. The diagnosis of carbon monoxide poisoning is suspected based on the history and clinical context. Diagnosis is confirmed by measuring carboxyhemoglobin levels. Levels more than 3% in non-smokers and more than 10 to 15% in smokers confirm exposure. Venous samples are acceptable for diagnosis, but arterial samples may be preferred to diagnose associated complications like metabolic acidosis. Pulse oximetry is not reliable as it cannot distinguish carboxyhemoglobin from oxyhemoglobin. Arterial PO2 may be normal as it reflects dissolved oxygen and not hemoglobin-bound oxygen. Other testing includes EKG and cardiac enzymes to rule out myocardial injury and chest X-ray to rule out congestive heart failure and pulmonary edema. In the acute stages, brain CT and MRI are usually not helpful, but in the later stages can show lesions in the globus pallidus and other brain areas susceptible to hypoxia. This figure shows T2-weighted brain MRI images of a 29-year-old woman with carbon monoxide poisoning at 1 day and 2 weeks, which shows destruction of the globus pallidus. In this image, the CT scan on the left in a patient with carbon monoxide poisoning shows diffuse hypodensity of the gray matter involving cerebral cortex and basal ganglia, and the FLAIR MRI on the right shows bilateral cortical hyperintensity involving the temporal lobes, including the medial temporal lobes, right more than left. Management includes removing the patient from exposure, administer 100% high-flow oxygen via non-rebreather mask. Comatose patients need endotracheal intubation and mechanical ventilation with 100% oxygen. High-flow oxygen should be continued until the carboxyhemoglobin levels fall below 5%. Hyperbaric oxygen therapy. This is most beneficial when administered within 6 hours of exposure. Benefit beyond 12 hours post-exposure is unproven. One session at 2.5 to 3 atmospheres is typically recommended, with additional sessions as needed. Indications for hyperbaric oxygen include carboxyhemoglobin more than 25% and more than 20% in pregnant patients, loss of consciousness and coma, cardiac ischemia, pulmonary edema, and respiratory failure, severe metabolic acidosis with a pH of less than 7.1. Studies indicate that hyperbaric oxygen reduces both short and long-term mortality, particularly in patients under 20 years and those with respiratory failure. This image shows a picture of a hyperbaric oxygen chamber. Prognosis: delayed neurocognitive deficits persist in up to 40% of patients. Myocardial injury is associated with significantly increased long-term mortality. Risk of seizures is increased after severe exposure.